there's a real paradox about Australia, and the paradox is this: we live in, by any definition, a lucky country. We've got a first-rate medical system. We've got amazing practitioners, and yet we have some of the worst mental health statistics in the world. And it's worth just thinking about that for a moment. We have the second worst, after Iceland, mental health statistics in the world, and that was before COVID. So 2 years later, they're going to be worse. And what we tend to do is we tend to think about process changes to improve the situation. So governments talk about putting in more funds in order to improve patient access gateways and make the patient the center of the system, and make sure we've got more psychologists and more psychotherapists and more psychiatrists, all of which sounds great. But as we'll see, there's a real elephant in the room. And the elephant in the room is that the treatments just don't work very well for a large number of people. And for some people, they don't work at all, people who are treatment resistant. And for those people, it's really agony, because their suffering is not something that it's easy to help them with. And a subgroup of those people will go on to harm themselves, and a further subgroup will go on to commit suicide. So this is a real problem in this country. And what we're not doing is trying to look at it from a different angle. There's a great saying, and it's sort of very apt in this context, and that is that insanity is doing the same thing time and time again and expecting a different result. So what we're going to talk through today is a really exciting development in medicine. It's coming towards us now quite quickly, and it will really increase the treatment paradigm available to health practitioners in a way that will get many more people well and out of the system. And wouldn't that be a good, for those of you who are working in the system, wouldn't that be a great thing to see many more patients getting well? So with that as just a brief overview, let's run the video, Gavin, and then we'll get straight into the presentation.
Yep, sure thing. I'll do that now. Just give me 1 sec. All right, video share. All right, can everyone see my video screen? I will disable video panel. All right.
Did you know that over 45% of Australians will experience mental illness in their lifetime? That's nearly half of us.
Everything feels flat and dry. I feel ashamed.
Mental ill health devastates lives and families and costs Australians around $60 billion a year. Research and treatment expenses continue to rise, yet rates of mental illness indicate that we're losing the battle. New approaches are urgently needed to address this immense suffering and cost. Psychedelic-assisted psychotherapy is currently being trialled worldwide and has demonstrated remarkable promise in treating depression, anxiety, addiction, and post-traumatic stress disorder, with new trials underway for treatment of dementia and anorexia. The treatment combines a short program of psychotherapy with just a few medicinal doses of psilocybin or MDMA. In the 1950s and 60s, psychedelic treatments had a major impact in psychiatry, and many considered it the next big thing in mental health treatment. But for political reasons, the Nixon administration criminalised the use of psychedelics and effectively stopped all research. That research has finally begun again. With proper clinical support, psychedelic treatments are safe and frequently lead to remission after only a short program, and even where current treatments have failed. Here at Mind Medicine Australia, we believe everyone should have access to the best treatments for mental illness. We will seek to establish best practice in regulated psychedelic-assisted treatment. Mind Medicine Australia is wholly focused on the clinical application of psychedelic medicines. We're preparing for change by developing therapist training, ethical guidelines, a centre of excellence in psychedelic medicine, educational material and events, and supporting clinical research. We're a small organisation doing big things, and we need your support. Please share this video and visit our website to support us and get involved.
Okay, well, let's get straight into the presentation. You're going to put it up, Gavin?
Yep. Here you go.
And please come through the chat with any questions, and Gavin will endeavour to answer them as we go through. And then there'll be time for questions at the end. I'm going to move quite quickly, but there'll be time to come back to any particular slide or issue at the end. So keep going. Okay, keep going. All right, now this is a slide that's really, I find really sobering. I'm sure you do as well. These figures are all pre-COVID, so they're going to be worse now. At 1 in 5 Australians with a mental illness, pre-COVID. What I found staggering was 1 in 8 Australians on antidepressants. It's a real sign of a system that's not working effectively, where you see almost 100% increase in the use of antidepressants over the space of 15 years, but the mental health statistics don't get better. And there you'll see almost 1 in 2 of us in our lifetime is going to suffer a mental illness. Those mental illnesses down the bottom just happen to be, and they're all major mental illnesses, they just happen to be the mental illnesses where the most work has been done with the use of psychedelic-assisted therapy in trials with those particular disorders. Okay. All right, if the general population is bad, then when you start getting into subgroups, it can be even worse. And the one that really stands out is ADF veterans, and their position is truly shocking. And it's not only the higher incidences of mental illness, but it's the higher incidences of comorbidities. And for those of you who practice in this area, you'll know that it's even harder when somebody presents with multiple comorbidities. So it's no wonder that we constantly see stories of veterans committing suicide. Next. Massive costs, not just economic costs, by the way, but also costs to us as a society. There are a number of entrenched social problems which at their heart, you see mental illness, such as homelessness, domestic violence, recidivism with prisoners who come out and then go back in, and so on. As I say, a major cause of suicide and homelessness. Okay. Now, this is the elephant in the room, which no one's speaking about, and that is fundamentally the treatments that we have really haven't improved outcomes now for about 50 years. So we desperately need innovation. Innovation is something that's talked about a lot in Australia, but unfortunately, we talk about it a lot, but often we don't actually practice what we talk about. Next. So these are the bare statistics. No appreciable improvement in treatment outcomes for 50 years. If you've got depression today, or your son or daughter does, or a friend has, they've got about a 35% chance with existing treatments of getting well, going into remission. They've got a higher response rate, but even then, you're talking about a response rather than colloquially getting well. The major pharmaceutical used is obviously antidepressants, SSRIs, and they can have nasty side effects. And the thing about SSRIs is if you ever wanted to condition somebody to see themselves as mentally ill, you would give them a pill to take every day just to remind themselves that in fact they have a mental illness. When you get to PTSD, and we have a lot of trauma in our society, but when you get into this area, it's even worse. So, a woman who was molested when she was a child, and as a result suffers PTSD, she's probably got less than a 10% chance using existing modalities of getting well. Now, if you just think about that for a moment, that's a truly horrific statistic. That woman or man, if whoever, has got a relatively, a very small chance of leading the normal life that we all want to lead, a life of quality and a life of health. So, we can kid ourselves, but actually if we're just going to do the same again and again and again, we're going to get the same result with mental health statistics. They're not going to turn around, and probably because of the acceleration in our lives through technology, they're probably going to get worse. Next. All right, just a few words about Mind Medicine. We are very much a charity. Tanya and I set up this charity 3 years ago. We've got an amazing team around us, but it's a relatively smaller team that does amazing things. Our major focus is on increasing the treatment paradigm in Australia so that health practitioners and their patients have more options. We're focused on psychedelic-assisted therapies simply because the trial data, as I'll come to, is so good. We're going to focus largely on psilocybin and MDMA for the time being, simply because the psychedelics, or as in the case of MDMA, something that people often refer to as a psychedelic, they're the most advanced in trial work. For us, success is very much seeing these as an integral part of our mental health system. We want to see high remission rates, so more and more people get out of the system, and that will hopefully release resources. And if our politicians and bureaucrats are honest, those additional resources will then go back into the sector to look after people that, for whatever reason, these therapies don't work for. We want to see, as I say, those high remission rates, substantial improvement in statistics. And the last one is critical to us, and that is that these therapies must be available to all Australians wherever they live and whatever their financial circumstances. We do not want these to be therapies that are available to wealthy people in cities. We want it to be available to any Australian that needs them. Keep going. We have an amazing board, and I won't go through the names, but they really are an extraordinary group of people. Keep going. Great management team. Then when you look at our ambassadors and advisory panel members, and I'm not going to single them out individually, but we have an extraordinary group of leading researchers from around the world: psychiatrists, psychologists, psychotherapists, religious people. The reason we wanted religious people there is we wanted to really emphasize that this is not that psilocybin and MDMA are not a religious issue, that anyone who looks at the data can get their mind around the fact that these should be part of our medical system. So just keep going. These names are all on our website, so please look at the website in more detail. We had an amazing in our CPAC course. We had an amazing presentation from Wade Davis, who's an advisory panel member. He's a leading anthropologist, and he really took us through the history of the use of psychedelics with Indigenous people, really from the dawn of time. And it was a fascinating lesson in the fact that psilocybin and other psychedelics really go back to the dawn of human existence. Okay, so let's now get right into these therapies. As I say, we're going to focus on psilocybin and MDMA. Psilocybin's mainly been used in trials for depression, but we're starting to see it being used with OCD and also addiction. And medicinal MDMA used predominantly for PTSD, but there's a couple of really interesting trials where MDMA therapy has been used for addiction very successfully. The beauty of these medicines or these therapies is that we're only talking about 2 to 3 dose sessions. So they're completely the opposite of taking antidepressants day after day after day. I should add here that what's fundamental to these medicines is that they're structured around psychotherapy. So the core ingredient here actually isn't the medicine, it's the medicine with the psychotherapy. We're talking about therapies that are curative rather than palliative. Therapies that are very safe in medically controlled environments and non-addictive, and therapies that have breakthrough therapy designation with the FDA, which is only granted by the FDA in America, where they see a new modality as being potentially significantly better than existing, for serious illnesses, than existing modalities. So keep going. All right, so a couple of words about psilocybin and MDMA. For those of you who've never experienced these medicines, they're fundamentally different. With psilocybin, you take the psilocybin, after about 20 minutes, you start seeing different coloured lights. You think you're seeing them in your eyes, but you've got eye shades on, so what you're seeing is your brain's representation of colour. And then if the dosage has been done properly, you're literally transported into another level of consciousness. During the actual medicine session, you're not going to be doing a lot of talking because you're going to be really in another world. And when you come out of that, you're going to feel incredibly connected. Medicinal MDMA, which is being used for PTSD, is fundamentally different. You take the MDMA and after about half an hour, the medicine starts to have an effect. The effect it has is to make the person who suffers serious trauma feel much more relaxed in the therapeutic environment. And in that environment, they can start opening up with their therapist about what happened to them without retriggering the original emotions that have caused all the damage. So it's a medicine that actually makes the therapy much more meaningful because the person taking the MDMA is more relaxed and feels that they're in a loving, trusting environment, and therefore can start talking about things that happened to them, sometimes decades before the treatment. This is a typical room where the therapy occurs. It takes place in a medical environment. So this is a hospital, but the room is decked out to feel very much unlike a hospital. You'll see there the person is lying down. They've got eye shades on. They may have earphones with a playlist. And the whole idea is to make them as comfortable as they can, consistent with the fact that they're going to take a medicine which is going to have a significant effect on them. You've got two therapists with them at all times. The best protocol says it should be one male, one female. And the reason for that is, one, so the patient feels secure, but secondly, to make sure that nothing untoward happens to the person whilst they're in an altered state, that we can make sure that the therapists themselves are being monitored. Keep going. This slide is sort of interesting, and some of you who live in Melbourne may have seen the coroner's report that came out a few days ago, which analysed deaths due to drug use over the last 10 years. And what was fascinating about that was that psilocybin didn't appear in that list, and MDMA was very, very low on that list. What was high were the abuse of pharmaceutical medicines. So antidepressants, benzos, and other medicines that are taken home by the patient, and for whatever reason, the patient overdoses on them. Next slide. This is where it sort of gets interesting, because when you start looking at testimonials or hearing testimonials about the treatment, you get these incredible comments being made. I felt like I went through 15 years of psychological therapy in one night. MDMA is the reason my son has a father instead of a folded flag. Everyone deserves to have this experience. Wars would be impossible to wage. They really are transformational medicines, provided they're used in the right environment with the right supervision and the right controls in place. So very different from traditional medicines. Next one. Okay, so for those of you who love getting into the stats and the research data, this is where it does become very interesting, because when you look at antidepressants, which is obviously a major pharmaceutical being used for depression, what you see there is an effect size of 0.3. That's a small effect size, so it's not a great deal better than placebo. When you then compare it with these therapies, psilocybin for depression and so on, what you see is an effect size which is a multiple of the effect size of existing pharmaceuticals like SSRIs. Next one. All right, so now we're moving to a discussion on psilocybin, and I mentioned before how it worked. That you go into that room in the clinic, you lie down, you put on a face mask, you have a playlist of music. You take the medicine, and after about half an hour, if the dose is right for you, you are literally transported into another world. What's actually happening in your brain, and these are representations from fMRI scans here. On the right-hand side, you see the placebo, which is really probably everyone on this call, including me. As we go into adulthood, our minds become much more structured, and we don't have the versatility, most of us, that we had when we were children. And that's because, from experience, we've learned what is safe and what isn't safe. and all sorts of biases go into our minds. Now, with a depressed person, it's even worse, because with a depressed person, they tend to ruminate. And rumination is all about, I'm not good enough, no one loves me, I haven't got a future, and so forth. What these medicines do, when you look at them under fMRI scans, is they reconnect the brain. And you see here a massive neurogenesis taking place. So it's little wonder that when somebody comes out of this experience, the common comment that they make to their therapists is, I feel incredibly connected. And no wonder, because they are connected. Well, that's what the medicine has done to them. And this is where the therapy is so important, because the task of the therapist then is to bring that sense of connection, that sense of wonder back into their lives. And if you can do that, then what you'll see is very high rates of remission for depression. So very exciting. Next one. The other exciting thing about psilocybin is, and this is one of the trials that was done, but you see it really in all of the trials, and that is that the remission rates increase over time. So think about it, with an SSRI that the doctor gives you, what often happens is you may get a benefit, and then unfortunately what happens is that the benefit starts to decline over time, and the doctor then says to you, I'm going to double the dose, or I'm going to change your antidepressant. And you go through that same sort of cycle. Initial benefit, but then it winds down. What you're seeing here is that the initial remission rates, which are already high at the 5-week stage, here at about 60%, are around 70% 12 months later. And the reason they're increasing is what the patient is doing is the patient is integrating the experience, the worldview, into their own lives, that sense, that critical sense of connection. Next one. MDMA, as I say, is different because, you know, if you and I had taken psilocybin, there's nowhere in the world we'd be having a sensible conversation during the experience. We literally are in a different or an altered state of reality or consciousness. With MDMA, you can still use your intellect. You can still talk to your therapist about what happened to you. The therapist can try to encourage you to open up, but you're doing so in an environment where you feel incredibly safe. So as I say, you know, if you've got PTSD, if you've got serious PTSD, there's a real challenge for the health practitioner, and it's this: the pharmaceuticals don't work well, which means that the heavy lifting is left to the psychotherapists. The problem a psychotherapist will have is that what the psychotherapist wants to do is get the person to unburden themselves about what happened to them. But that carries with it a serious risk, because it means that stuff will be coming to the surface with that individual, which may have been buried for the last 30 or 40 years, because that's a safety valve for that particular person. And that's why in the early stages of therapy, for people who deeply suffer from PTSD, suicidality can actually increase. So it's a period which has to be managed very, very carefully by the therapist. What you're seeing here is the phase 2 and the phase 3 trials. And you're seeing extraordinary remission rates. You'll see there with the phase 2 trials, you had remission rates with people that had an average period of PTSD of 18 years of 52% increasing to 68% at the 12-month mark, and similar results in the first stage of the phase 3 trials, which had a larger number of people going through the particular trial. And interestingly, not only were there much higher remission rates, but suicidality was virtually non-existent. So in fact, these therapies, based upon that phase 3 trial, are actually safer than traditional psychotherapy when you're trying to get somebody with severe PTSD to start to talk about what actually happened to them. And it's safer because the person feels more relaxed, more comfortable, more in a loving and supportive environment. Next slide, Gavin. Again, last year really was a pivotal year for psychedelic medicine. You see there the phase 3 trial, which I've just talked about, MAPS in the US. It was a multi-site trial. It also included a site in Israel. That was MDMA. The second one was Imperial College, the first head-to-head between SSRI plus therapy and psilocybin plus therapy. And what you see is that in terms of remission rates, the psilocybin plus therapy was about twice as high as for the SSRI group. And I would bet that the SRI group benefited in part from the placebo effect. But anyway, even allowing for that, the psilocybin group remission rates about twice as high and lower adverse effects. Next slide. Now, what's happened in Australia, and it's really been the result of Mind Medicine advocating in Canberra, is we've seen the Australian government announce a $15 million grant round, the largest when it was announced of any government globally. And that has led now to a significant number of new trials being conducted in Australia. And whilst Mind Medicine is really keen to see these therapies being used as soon as possible on a patient-by-patient basis, and I'll come on to that, we do also recognise the importance of ongoing trial work to improve the efficacy and effectiveness of these therapies, and to broaden the scope of treatment to other mental illnesses. Next slide. Yeah, we'll keep going. We can come back to Ibogaine if anyone's interested in that. The other thing that's happening, which is really exciting, is that globally we're seeing countries start to open up. And I won't go through all of these in detail, but the important thing here is we're seeing expanded access schemes, which are schemes that you can use for unregistered medicines, where you can gain approval from the government to use an unregistered medicine, opening up in America, Canada, Israel, Switzerland, and in Australia as well, where psychiatrists are getting approvals from the TGA. But in Australia, because we have this dual federal state system, we're having problems with state governments. And I'll come on to that later. We're seeing Oregon in the States legislating for the medical use of psilocybin therapy. And we're seeing the Canadian government recently adding psilocybin and potentially MDMA to its expanded access scheme. Next, Gavin. This slide is actually what really sort of got Tanya and I very excited when we were doing our early research. And that was the caliber of the universities doing the research. You know, these aren't peripheral third grade universities, these are leading universities. And the quantum of research that's been done at these universities and the leadership that they've shown is something that I think we're all going to be very thankful for in the years to come. Next, Gavin. The other thing that's been happening is individual universities have been announcing centres of excellence. And we've now got 9 around the world. When we started, there were 0. And again, that's showing the momentum that we're seeing around the world for these therapies. If you go on to the next page, Kevin. That last one is the Australian one, the Neuromedicine Discovery Centre at Monash University. That was announced late last year. That was the product of us working with Monash to establish a centre of excellence in Australia for the development of psychedelic-assisted therapies in this country. And the reason that's so important is that regulators and health practitioners understandably want to see leading universities researching these therapies to improve our understanding of how they work and improve the ambit of treatment. So that's very exciting. Keep going. In terms of historical comments, like I'm not going to go through this other than to say what I said at the start. For almost the entire duration of human existence, psychedelic medicines have been legal. They've been legally accessible. Now, in most cases, they've only been accessible through specific environments, so sacred environments, where there's been ceremony leading up to the taking of the medicine. But it's only been in the last 20 years, the last 50 years that we've had these laws preventing access to these substances. There was a massive and really interesting use of these substances in the 50s and 60s in psychiatry, and they really were seen as the brave new world of psychiatry. And keep going. Then this gentleman on the right, who those of you who are old enough to understand that period will recognise as President Nixon. Nixon in the late 60s had a problem. His problem was the anti-war movement. Young people basically saying they didn't want to be conscripted and weren't going to be conscripted to go to Vietnam and fight a war that they couldn't understand the sense of. The problem he faced was he couldn't stop young people demonstrating. But what he noticed was a lot of those young people were actually taking psychedelics. So what he did was outlaw those psychedelics so he could then imprison the leaders of that movement. So anyone who believes there was science behind these rules against psychedelic medicines, actually, there is no science behind the war on drugs. It's all about punitive measures to stop people demonstrating against a war, which most of us looking back would say was a really unjust war, conducted in a terrible way. As David Nutt says there at the bottom, this is he would say the worst example of censorship of research and medical treatment in the history of humanity. Next slide. What that meant was that from 1970 onwards, you had a massive reduction in research on the use of psychedelic-assisted therapies. Now, we've effectively had 50 lost years where we've seen massive increases in mental illness in our society, and our medical practitioners, our health practitioners, haven't been able to access these substances as part of therapy to help their patients. So it's a real indictment of the way governments can work to deny people access to something that's safe and effective if conducted in the proper environment. Next one. The other thing that's been happening over the last 3 years is we're seeing a massive growth in private sector interest in these medicines. Now, you know, the good old private sector loves the big problem. And as we all know, mental illness is a massive problem, but they only love a big problem if there's a big potential solution. And what you're seeing now is probably 100 not-for-profits being established over the last 3 years, all focused in one way or another on psychedelic-assisted therapies, because they see this as being a paradigm shift in the treatment of mental illness, and therefore an ability to build a business around that. And all of us, you know, will have different views about the capitalist system, but if we're ever going to scale these medicines and make them available to people right around this country of ours, we have to have private sector capital to do that. Because in the early stages, it's going to be very hard to get the necessary capital from government. Next slide. Next slide. All right, now this is, I've gone pretty quickly, but this is the last slide I wanted to take you through, and it's really how Mind Medicine Australia is positioning itself. I said at the start that our objective was to develop the ecosystem in Australia so that this became a natural part of our medical system, available to patients and their doctors, but only if the doctor and the patient believe they're appropriate. So what Mind Medicine isn't trying to do is get involved in the patient medical practitioner relationship. That's a sacrosanct relationship. We just want the medical practitioners, the health practitioners, to have more options. So 4 key strategies to make that happen. The first one is awareness building. So, you know, what we're doing today is very much part of that. And Tanya and I and others at Mind Medicine are doing this virtually daily to governments, you know, regulators, politicians, health practitioners, psychiatrists, members of the general public, politicians generally, to build awareness so that people start to realise that actually there's a game changer that's coming towards us and we need to start investing in it to make it happen as soon as possible. We have over 30 chapters around Australia, so if you're interested in this after this call, please look at joining one of our chapters. The second thing we've done is we've established training courses in these therapies, and we're doing that through an organisation that we've established with 2 amazing clinicians, Dr. Trell Dowie and psychologist Nigel Denning, and that's the Mind Medicine Institute. And what the Mind Medicine Institute does is provide clinical training to therapists, psychiatrists, psychologists, and so forth, to enable them to use these therapies when they're legally able to use them. And one of the reasons we established Mind Medicine Institute and these courses was a simple reason, and that was we foresaw that the regulators would get more and more interested in this, but they'd be saying, well, they look interesting, Peter and Tanya, but we don't have the therapists who know how to do them. So this course is really so that we can turn around to the TGA and state governments and say, guys, we actually have the therapists who've been properly trained, and that should give you a lot of confidence in the ability of the system to accommodate the use of these therapies. The third strategy is all about getting the university system to buy into this. And I mentioned the Centre of Excellence at Monash. And I also went through a lot of the research that's now being done by the university sector, which is fabulous. And the last thing there is all the myriad of things that has to be done to leverage these medicines and therapies through our medical system. So that's changing the regulatory environment, that's bringing in the right sort of protocols, the right ethical frameworks, the right rollout strategies, getting clinics to start doing research, and all those things that will make these therapies available right across this country of ours. And as part of that, we give a lot of thought, not just to making them available in cities and large regional centres, but how do you roll them out right across regional Australia so people who are distant from major cities can also have the benefit of these therapies. So that's My Medicine Australia and what we're trying to do. Would love to answer any questions that you have. This is an extraordinarily exciting area, and I hope you're all feeling the excitement. It's come a huge distance in the last 3 years. It's accelerating. What we now have to do is collectively get it over the line so that the practitioners on this call and around Australia who have patients that need these therapies will be given access to them and will be given a real chance to go into remission and lead the lives that, frankly, every human being in this country should be entitled to. Let's stop accepting the terrible mental health statistics and messing around with process. Let's get to the heart of the matter, which is treatments that are effective and can get people well. So you can see my beautiful wife on the phone, on the video, Tanya. Gavin, do you want to call out any questions that you think I should address?
Yeah, totally. And I'm happy. Tanya, would you want to jump in as well at all? Or? All right, here we go. Let me unmute Tanya.
Hi.
There we go.
No, I just wanted to say hi and what a great presentation, Peter, and thank you so much to all of you for being so interested and so supportive, and there's some wonderful questions and comments. And Peter, did you go through, because a few people I think did you have that slide on how to help?
Yeah, let's go to that, and then we'll go through some of the questions in the chat.
Okay. Shall we just put that how to help slide on for a moment, Gav?
Yeah, sure. Give me 1 sec. I'll pull that up.
Thank you for all your supportive comments, everyone.
Particularly the one about having some rain. I like that.
Yeah.
All right.
Oh, thank you. Great. So yeah, just a comment to all of you. Look, you know, this is a movement, and we can't do this without your support. So it doesn't matter, you know, how great our team is or our board or anyone else. This really is about tens of thousands, hundreds of thousands, millions of people just going, we cannot wait for these treatments any longer, and putting political pressure on politicians. And also there's many medical practitioners on this webinar today, and of course we have many medical practitioners who are supporting our work. And for each of you, I just encourage you to speak to other medical practitioners. So here's the ways you can help us. There's all sorts of volunteering opportunities. We have chapters all around Australia, so you could join those or start one of your own if there's not one near you. We have a wonderful Learn section on our website. As I mentioned, you know, speak to every doctor that you see. Every time I go to a GP, I talk about these treatments, and even if they don't know anything about them, they become interested, and many of them actually end up registering for our training and so on. Have we talked about our training at all, the CPAT course?
I only briefly, Tanya, in
okay.
with My Medicine Institute.
Okay, so we might just show that slide just briefly too. And then, of course, you know, we encourage you to support us, to donate, to support this movement. We absolutely can't do this alone. To talk to your MPs. And we have lots of wonderful webinars. So we have a wonderful webinar series coming up as well. We might just flip through just very briefly these other slides. And yeah, this one. So this is the certificate in psychedelic-assisted therapies, which is open for psychiatrists, GPs, psychologists, psychotherapists, occupational therapists, social workers, nurses, counsellors, paramedics, and others. So this is a wonderful course. Professor David Nutt recently described it on ABC Radio National as the best course of its kind in the world. And we have people on our faculty like Dr. Gabor Mate, Dr. Ron Siegel. The other day we had an absolutely stunning presentation for the CPAC course from Dr. Wade Davis. It really is extraordinary. The next slide. And, oh, that's it again. And the next one. We have a 4-week online course as well. So we've just announced a new intake of that. And the next slide. So these are some of the upcoming events. So you can see some of the webinars that we've got on this slide and also the next slide. Yep, and that question, Clarissa, that you asked, do mental health support workers, can they apply? Absolutely, please apply. So we'll take off, I think we'll take, oh, Peter, you will have mentioned the rescheduling submissions.
I'm going to get onto that now, Tanya.
Oh, cool.
Yeah. Look, some of you are asking about how do you actually access these therapies? And at the moment, there are 2 avenues in Australia because these medicines aren't yet registered medicines. They're going through the process overseas. There's a good chance MDMA-assisted therapy will be registered medicine in America in about 2 years' time, and psilocybin maybe in 4 years' time as part of therapy. And that then will hopefully translate to these becoming registered medicines in Australia. But at the moment, there are 2 ways that these medicines can be accessed. The first is through trials. And we're seeing now a significant number of trials being developed and more to be announced soon. And they're trials, you know, psilocybin for depression, MDMA, PTSD, and a whole host of others.
Would you like to just mention the one for therapists, Peter? The one, because that's a wonderful for everyone to know about that.
Yeah, the one that Tanya's mentioned is that, as we talked about, we've got a therapist training course, which is world leading. But one of the challenges if you're a therapist is if you've never actually taken the medicine, how do you actually know what your patient's going through? You know, I can talk hopefully eloquently about a psilocybin experience, but if you've never taken psilocybin, I can't get you to understand what it's really like because words actually are insufficient. So how do you get therapists to really understand what the patient's going through when these substances are illegal in Australia? Were you to take them and were you to be caught, you know, you'd be potentially in deep trouble. What we've done there is we've got ethics approval for a healthy person's trial, which will enable people who graduate from therapist training courses in these therapies to actually experience MDMA and psilocybin as part of a group, properly organised with proper supervision, but to do that legally. And we're going to do it in a really interesting way. So for MDMA, we're going to do it by up to 7 therapists. When I say therapists, I'm including anyone who's graduated from the training course. So that could be psychiatrists, psychologists, psychotherapists, and so forth. We're going to have up to 7 at a time sitting in a circle, and they'll take the MDMA, and then the facilitator, and there'll be therapists in the room making sure people are being properly looked after, and there'll be a doctor on hand, although the safety of these medicines is very high in a clinical environment. They'll take the MDMA, and then the facilitator will start to get people in the circle to talk about their lives. And you know what it's like when you're in a group and you're asked to talk about your life. You tend to talk about relatively easy subjects like, you know, I trained at so-and-so, and I've got 3 sisters and 2 brothers, and my younger brother drives me mad, and my older mother's got a problem. You're talking fairly generalized ways, and you tend not to talk from the heart. What's going to happen is, as the MDMA starts to have an effect, it's going to be fascinating, because the inhibitions of people are going to break down, and the people in that circle are going to start to talk about themselves in a way that they probably wouldn't have believed possible, because they're going to feel incredibly safe, incredibly supported in that environment, and there'll be a real opening up. And why do I know that's the case? I know it's the case because back in the 80s, MDMA was used for couples therapy. It was used for couples who are having marital problems, and the therapist would give the couple some MDMA, and suddenly after about half an hour, rather than the couple sort of attacking each other, they'd start to be talking all lovey-dovey, and all the initial passion and love would come out that they initially felt for each other.
Wouldn't you like to be a fly on the wall for this trial?
So that's MDMA. Psilocybin is very different, because, as I said, that will be done in groups, but the experience is a very personal experience. But the benefit of the group doing it in groups is that when you come out of that experience, there'll be other people in the group who have gone through that experience with you, who you can share what you went through, and they can share with you what they went through. And the beauty is that all of you, I'm saying all of the people participating in that group will have gone through the experience. So again, you're going to have a fascinating post-experience discussion about what the meaning of it is, what the meaning of consciousness is, what does consciousness mean? How many levels of consciousness are there? What does the religious experience mean? What's a mystical experience? Have I just been through one? Because you probably will have been through one. So that's the Healthy Persons trial. But as I say, there's
I'm just conscious there's a lot of questions here. Do you want me to start just racing through them so that we can?
Yeah, but just let me finish, Tanya.
Yeah.
2 routes to get it at the moment. The first one is through trials. The second one, and this is obviously for patients, and that's through Special Access Scheme B. That's a patient-by-patient approval process that the TGA gives to psychiatrists, and we're getting approvals through for psychiatrists within about 24 to 36 hours. The problem at the moment, and it's a really ridiculous problem, is that for historical reasons, these medicines are Schedule 9 of the poison standard, prohibited drugs, and the states and territories of Australia, bless them, don't recognise that these can be used as medicines whilst they're Schedule 9, even if the TGA has given an approval. So what we're doing now is we've applied to have them rescheduled to Schedule 8, and we'd love you all to get involved during the public submission period, really saying to the TGA, it's time for these medicines to become part of our medical system on a sensible, careful basis. So why don't you go through the questions, Tanya, that you think are most pertinent, which we can respond to?
Yeah, absolutely. So, by the way, if you want to put up your hand, we might be able to take a couple of people who want to ask questions by putting up their hand as well. But we're going to go through these super fast. I'm just letting everyone know.
By the way, that last one about the post-MDMA crash, that's much more experienced with recreational use of MDMA.
There is no evidence of that in the actual MDMA trials at the doses that are being given.
So again, this is where we have to separate recreational use, where people often combine it with alcohol and other activities where there isn't dose control, where they might party all night with something that's very carefully controlled and in a medical environment. They're completely different in terms of the way they're conducted.
Okay, so there's a question here. I'm a physiotherapist working in the NDIS mental health space. I have a client who really needs this. How can I go about accessing it? And so that really goes to being either part of one of these trials, or as we said, we're going to be working on the rescheduling. And of course, then what we're seeing at the moment is a number of approvals being granted through the Special Access Scheme as well. And thank you to Kim. We appreciate your comment. MMA are doing an incredible service to current and future generations of Australians. Hopefully we can continue to do that. We can't continue to do that though without all of your support.
That's the point. This has to be a movement. And it's a movement for change, and it has to keep getting bigger and bigger and bigger. And that's why, you know, if each of you can pass this news on to 10 of your friends and get them infused, you can just see how it starts to go right around Australia, as it is doing, because, you know, Australia is much more aware of these therapies now than it was 3 years ago.
Question here from Mandy. Will this advance through regulations, policy procedures and frameworks to be administered in community-based clinics?
Yeah, I mean, there's no reason why, you know, what in terms of the rescheduling, what we're talking about is a controlled medical environment. So it has to be a clinical environment. And, you know, there'll need to be a doctor on site. And that's precautionary because in the trials, there's been very little in the way of significant adverse events. And there'll need to be trained therapists. But, you know, if we can get the rescheduling through, then there's no reason why, with the assistance of a psychiatrist who will need to do the review of the diagnosis of the patient, i.e. the screening, there's no reason why it can't be used in that sort of environment.
Yeah,
and it's
so
going to be fundamental.
Community as well as private clinics is what.
Yeah, and it's fundamental because, you know, if we're going to spread this right across Australia, we've got to get every avenue involved over time. Yeah, to make that happen.
From Kathy here, Kathy. Not sure where you are, but this is a really good point. I work as a lived experience advisor within the mental health system. I know that, I understand that MMA has ambassadors speaking as lived experience, people with lived experience with the medicines and so on. But I wonder if you have engaged the lived experience consumer workforce or peak bodies as another potential source of support and knowledge exchange. Now, this is an extremely important point, Gavin, which I'd love you to note. And Kathy, I guess what we'd love from you, if you're there and you can put yourself on video, is, hi, thank you so much for that comment. What I'm wondering is, yes, I mean, we do know who some of those bodies are and we have had some connections with them, but would you mind reaching out perhaps to me and letting me know who we should reach out to? Gavin, could you put my email into the chat? And Kathy can reach out, or anyone can reach out to me, it's fine. And Kathy, we'd love your help to reach out to those lived experience peak bodies. And Gavin, I think this is something that you and Nicole could both work on, because there's like so many members of these. Some of these consumer bodies are enormous. Kathy, which ones are you particularly thinking of?
I'm based in Victoria, so I'm thinking of VMIAC, but there's also Being in New South Wales, and I think there's Comwa in WA. So I think that there's, it's quite a loose network as well, and very much a movement, and a very much a kind of bottom-up kind of movement that's also seeking to have massive influence on the mental health system. So
no, we really would love your help with this. So Gavin, is that there now? I think Gavin's probably put that in there for you, Kathy. But it's Tanya, Tania, at mindmedicineaustralia.org anyway. And I'm very grateful, and we're very grateful for this suggestion. It's a great suggestion. Thank you. And by the way, if you're in Victoria, where are you in Victoria?
I'm in the northern suburbs, but I see there's a chapter meeting next week that I'm hoping to.
Oh, good. Are you part of our Melbourne chapter?
Yes, I've just joined. Yeah.
Fantastic. Wonderful. I was going to ask that question.
By the way, you've got a question there about how much Psilocybin and Mdma is administered per session.
Yep, I'm coming to that one, but okay, if you want to answer that one quickly.
Well, just to say that it's becoming quite standardized now. In the early trials, it was sort of all over the place because people were trying to test out what worked. But now it is quite standardized, and with MDMA, depending upon the person and often the size of the person, it's somewhere between 80 and 120 mg, and there's an optional extra at the discretion of the patient and the therapist about halfway through the experience of a further 40 or 60. With psilocybin, you're not talking about mushrooms. You're talking about medical grade pharmaceutical psilocin, or sorry, medical grade pharmaceutical psilocybin, not everything else in the mushroom. So there it's a much smaller amount, and I think from memory it's about 40. But I need to confirm.
2.5. 2.5.
No, you're thinking of mushrooms, love.
No, I'm talking about the synthesized.
No, you're not. You're talking about mushrooms. Tanya's talking about 2.5 grams of mushrooms.
Okay.
Which is probably giving you away a bit, Tanya. We're talking about here of pharmaceutical grade psilocybin, which is the pure molecules, not everything else in the mushroom.
Thank you, Peter. Mary Jane, thank you for all your comments here. You've obviously had extraordinary, and we've connected before, extraordinary healing yourself through these treatments, and you've seen a lot of people go through this. I think your comments are very informative. Thank you very much. Clarissa, yes, mental health support workers can apply. Alexandra, why is schizophrenia excluded? Because basically any psychotic conditions at the moment are excluded. Psychosis, you're saying especially psychosis is triggered from PTSD. Well, in the cases that are in the trials, psychosis is not being triggered by the PTSD, or else they wouldn't have been allowed to go into those trials. However, there is hope. So for those people that do have psychotic conditions, or if you've got patients who've got them, many of the therapists and researchers in this field believe that these medicines will become available to those with psychotic conditions as more research goes on. So this is not a never say never thing. It's really just a matter of time, and they can only really, there's only so many conditions that can be studied at once.
Let me take one, Tanya. There's one here from Ria.
Oh, hang on.
How will you convince Australian lawmakers that they could hardly bring themselves to make cannabis medically available? It's a really good question. The answer is that there's a tipping point in every society. And, we saw it there with gay marriage. For a long time, it looked like the laws would never, ever get changed. And there was a lot of animosity towards the concept. And then we reached a tipping point with enough people saying, actually, this is ridiculous. We need to change the laws. And now we look back as a society, and I think most of us would say, what on earth was all the noise about? Something that we should have looked at many years before. Why do we differentiate on the basis of a person's sexuality? But the reason I say that is the same thing that happened with medicinal cannabis. Medicinal cannabis, horrible, terrible drug, for most regulators and politicians. And then the movement built up, and suddenly, we were seeing pictures of young kids with epilepsy, and the dam broke because enough people started to say, this is ridiculous. We need access to medicinal cannabis. Should also say that the trials with medicinal cannabis are far less convincing than the psilocybin and Mdma trials. So we have far more data to take to our politicians and regulators. The other thing I should say is that with medicinal cannabis, there was never an organisation like Mind Medicine Australia trying to develop the ecosystem. So at the moment, if you try to get medicinal cannabis, it's expensive. It used to be quite process driven, quite annoying. For the practitioners, it's now a bit easier, but what we'll endeavour to do as a charity is make sure that when this becomes legalised, it'll be done in a way that's really efficient.
Okay, so now, thank you very much, Peter. I'm just going to go through these super fast now. So firstly, Sonia, yes, an art psychotherapist. So we do actually have art therapists and art psychotherapists in our training programs, and you probably now know that being a psychedelic-assisted therapist or joining the course is like one of the most sexy professions or careers that you can take on. So if you have any chance of doing the course, we really encourage you to register. Our next intakes are in July, and they're more than half full. So there's huge demand, and we really encourage you to get your applications in, and we'll do everything we can to support you in terms of your qualifications so that you can hopefully get into the course. It's Hugh says, can it help with stuttering? And of course, Paul Stamets very famously talks about how the medicines healed his stutter in fantastic fungi. And
don't do it the way Paul did it.
No, not at the top of a tree.
To climb a tree and then take the psilocybin.
Yeah, exactly.
Question here, what schedule will these drugs be registered under our proposed scheduling? The answer is 8, controlled medicine, which is what happened to medicinal cannabis initially.
Yep. Mandy says, I'm currently an IV medication endorsed nurse with postgraduate in mental health. Do I qualify? Absolutely. So Mandy, please apply. Candice, thank you so much. I have to go, but I will start a club at my university and get stuck into. Oh, great. Gavin, would you mind noting that about Candice starting a university club and passing that on to Scott?
Yep.
Because we are trying to also start more uni clubs as well as chapters. Richard, yes, Richard, you should definitely research this area. So please reach out if you want any further guidance for research ideas. Novel research is a good idea, not just replicating what's been done before. We will be sending out an email in the next 24 or 48 hours, which will have the link of this recording, which will also be on our YouTube channel, and also a whole lot of links so that you can get involved and participate more. Sonia, to your question, well, you heard before we're going to have the healthy persons trials. So if you do join our CPAT training, you will be eligible to be part of that healthy persons trial that Peter spoke in detail about just before.
After you graduate.
No, isn't it? Can they
No,
not
under the ethics lab, you've got to graduate first before you're eligible.
Well, still, I mean, that could,
it's a 4-month course. It's not exactly.
You can graduate within 4 months of starting the course. So.
Yeah.
And the next intakes are in July. Alex, I'm mostly concerned about how accessible these treatments will be to the disadvantaged. Yes, so that's a huge consideration of ours. And Alex, you're an aspiring social worker. Our goal really is to create a fund to enable those who are less fortunate to be able to be part of, have access to these treatments. I mean, we are a charity and we're very focused on equitable access.
But again, over time, what should happen is these therapies should become part and parcel of our medical system, and therefore receive the right sort of subsidies from government under PBS and MBS schemes.
Mandy, you ask, will MMA be formulating programs for group nurses to facilitate clients during treatment? And the answer to that is a definite yes. Linda, you've asked about the microdosing trial. I'm pretty sure you're there with your video there, Linda. Feel free to share that, of course. Linda, if you want any more guidance, please reach out to us and we'll see how we can help you. Linda?
Do you want me to unmute Linda so you can have a quick chat? Or?
I think if Linda, if you want to speak very briefly, you're more than welcome. Or ask a quick question. If not, that's fine.
I think the main thing here is that one of the beauties of what we're talking about is the more you get into the data and the science, and we have a lot of stuff on our website, the more exciting this becomes, because you'll find that a huge amount of work has been done in this area. The results that are being achieved are really good in terms of remission rates, and the safety data is very good as well. We've just got to make sure that it comes in with the right sort of controls and ethical standards, so that the patient remains right at the very centre of this, and people are properly trained and so forth. But
so we're going to wrap up. We're going to wrap up in a moment. Linda, did you want to speak briefly?
Can you hear me?
Yes, we can.
Okay. Well, it's just really, it's been very difficult for me to access psilocybin, to be able to microdose myself, and also to participate in a trial when you have to already be microdosing.
Yes. Okay. So maybe
it's a bit of a catch-22.
Is that the trial at Macquarie University?
Yes.
So can you not contact the people at Macquarie University and ask them for some guidance? Or
well, they've told me that they can't legally supply.
Yeah.
So
no, not we.
Yeah. So unless you had your own supply, and I did several years ago. It's very difficult, and you have to go on the dark web, and you have to have Bitcoins, and you have to do this and that, and have a virtual private network, and it becomes really complicated.
Yeah, can I just say two things? one, we're talking about medical doses. We're not talking about microdosing. And medical dosing is all about getting you into an altered state of consciousness.
Yeah.
And the second thing, which is I know incredibly frustrating, but we're very much taking the stance that this has to become part of the legal. It has to be legally approved.
Yes, absolutely. I agree, because if you're sourcing something illegally, you don't really know what you're.
No, absolutely, and that's the huge risk of it, Linda. Where are you based, Linda?
I'm in Perth.
Okay, well, look, a
Western
couple of
Australia.
things. Firstly, if you reach out to us, we can connect you to our Perth chapter, and that could be a handy, group of like-minded people for you. So why don't we do that to begin with?
Okay, sounds
Would
good.
you reach out to us for that?
Yes, we'll do.
Fantastic. And then
We've got a question here from Michael Owens, Tanya.
Yeah, Peter,
acupuncture.
Peter, I'm going to just race through the rest of these.
No, I'm just asking that one because I think acupuncture you can't you? Come into the CPAC course. You've got a question there about acupuncture being widely used in the US for PTSD in returned veterans. I'm an APRA-registered acupuncturist. Could I apply for the certificate course?
Well, by all means apply, and hopefully you'll be able to get in. So please do apply. I'm just not sure. It varies depending on qualifications, but please put your hat into the ring. Hugh, you ask about autism. And yes, this is being used for autism spectrum disorder. There's certainly research going on in that space. Sonia, we'd love your help in terms of any of your lived experience panel. How do you join the Melbourne chapter? Shall we start? Send us an email to hello@mindmedicineaustralia.org and we'll connect you to the relevant chapters, all of you, or send it to me and I'll connect you to the relevant chapters. There are Queensland chapters, yes, as well. Just let me see if there's anything else. Can I please have a link to discuss promotion and partnership with MMA? Yes. Has someone given that link to Mandy Webster?
And Nicole's put her email address in for that.
Okay. A University of Melbourne club shall, I don't know if I'm saying that correctly. Anyway, is there a University of Melbourne club? Not yet that I'm aware of, and we would love someone to start one. So if you would like to, please reach out to us and we can help you set up a University of Melbourne club. We have some at some other unis.
Hey, there's a really interesting point that's just come through from Joel. Hi guys, I'm a community pharmacist and I can see people who are put into the 1, 2, 3 plus medicines for depression and anxiety. I can vouch for those figures from MMA that current therapy does not work. But well done for paving the way. It's really important that people get the message out there that we have a system at the moment which is giving people medicines that don't work with a large majority of those people. And if they do work, they can often give nasty side effects. And they put people on a treadmill year after year taking antidepressants, every day taking a pill, which just conditions them to think about their mental illness. We do need a paradigm shift. And these therapies won't be for everybody, but they can make a huge difference in terms of the options available to clinicians and their patients.
Absolutely. Amy, you're doing an advanced diploma in transpersonal therapy. Definitely, apply, and even if I think that might qualify. I honestly don't know the full details.
So, yeah, if people have questions about whether they're specifically eligible, just email cpat@mindmedicineaustralia.org and our intake coordinator, Anthony.
Can you put that in the chat too, Gavin?
Yeah, for sure.
Thank you. Balaji, what technology is required to monitor the state of consciousness, alteration, vital signs? ICU is requisite.
No, ICU is not required. Right. They monitor blood pressure.
Yeah.
Which is they basically monitor blood pressure, and there's a doctor on hand just in case. But like in all of the trials, this is very safe.
Yeah.
And again, go onto our website and you'll see the safety data.
Yeah. Marjane, so because we're going to wind up very shortly. Marjane, Yes, Marjane, we definitely don't want just a pop a pill culture. This is very much about psychedelic-assisted psychotherapy. So it is very much the medicine plus the therapy, using that altered consciousness and that mystical experience really to get people well. Even though doctors don't like talking about mystical experiences, that is obviously a huge part of what is the healing process.
Yeah. And the other thing just to emphasize is that these medicines, when they're used in this way, are not addictive. And in fact, they're now being used to treat addiction.
Okay.
So we've got on our board an addiction psychiatrist, specializes in addiction, and he's incredibly excited by this because, treating addiction is, as you'll know, is incredibly difficult because often you're not getting down to the underlying causes of the addiction, which is pretty often trauma. And what these therapies are doing is getting down to that trauma. And that's why you're seeing what many people perceive as recreational drugs being used as medicine to help people come off addictive drugs. So really ironic that what we're going to see is these therapies being used to get people off standard pharmaceuticals that are being abused.
Yeah.
So listen, there's so many more questions. We can't get through them all, but if you've got questions and you want to send them in to us, we'll respond. There's a really interesting one here from Sanal about the Indian population. It would be fascinating to do a study with different demographics. Certainly, there are plenty of Indian people in many of the trials that are occurring around the world. And we can't imagine that they'd have very different experiences to, other nationalities.
This has to be culturally sympathetic.
Yeah, that's right. Caroline, is the course going to be recognised with APA? Which is APA? Sorry, forgive my ignorance, Caroline. Not sure if you're there, but we are certainly finding that a number of the peak bodies are endorsing, recognising or accrediting our training programs. Do you know which one APA is, Gav? I'm not sure which one APA is.
Well, we've got a APRA and an APS, but I don't know any APA. We've got an AMA.
But I think it could be any number of ones. Just let me just see if there's anything else. Oh, great. Other University of Melbourne's. Yeah, great. This person, Barbara Ann. Hello, Barbara Ann. So you're doing a diploma of counselling. Yeah, I mean, that definitely is a pathway to this training.
Yeah.
So please do apply. Hello.
There's another really good question there about, isn't this going to be driven by the patients in terms of demand? And the answer is yes. That's why it's so important that we get out there to as many people as possible how prospective these therapies are, so they in turn can put pressure on their politicians and regulators to get this happening as soon as possible.
Absolutely. Shanti, the CPAC course oversubscribed. Yes, I mean, if you don't get in the course, then there'll always be another intake. So we'll make sure you're looked after, and we will not take your money unless, you properly apply and you get properly treated. We do treat all applicants for our course with a great deal of respect. And even if you're not suitable at this moment or you're not fully qualified, we can give you advice on which qualifications you need to get into the training. Is it primarily patients who are going to drive? No, it's not just patients. It is absolutely medical practitioners. So good question, Josh. Definitely there needs to be a huge push from patients, but there needs to be just as much push from therapists, because it's therapists and doctors who know how substandard the current treatments are for the majority of patients. So it needs to be both. And the TGA, for example, takes very seriously how many medical practitioners submit. I'm just going to see if there's anyone else. Oh, Australian Physiotherapy Association. Maybe that's what that one is. And I don't know the answer to that one, but we can check that one out.
The psychotherapy, Tanya.
Huh?
Australian psychotherapy, I think.
Oh, no, that's PACFA though. That's the, oh, well. Barbara Ann, hope you feel much better with your appendicitis, and please do join our Sydney chapter. All right, I think, the American Psychological Association. Okay,
Oh,
I see. So our course is more recognised, endorsed, accredited by specific Australian peak bodies. So I don't think we'll be seeking accreditation at this stage from American bodies. But look, I just want to say a huge thank you to all of you for being part of this. We acknowledge all of you for the work that you do, if you're therapists or if you're patients or if you're family members of people who are struggling. We just want to say thank you to all of you for caring and for being on this journey with us. It's so important. And Sarah C, is there a danger of serotonin toxicity if a patient is already on SSRIs? There's mixed research on this. So in most cases, most therapists would say you'd want to taper a patient off their SSRIs before they undergo these treatments. But there has been some research that has just come out that does suggest that actually patients don't have to go off the SSRIs. But the problem is the SSRIs do block some of the neurotransmitters and receptors that would make you more receptive to these treatments. So it's probably preferable to taper off. That probably would be preferable. But we're happy, again, Sarah, if you want to reach out to us to do so. So for any of you, if you've got more questions, let us know. We'll get a thank you note out to you in the next period with this link. And please do join the chapters. Please spread the good word. Thank you so much, Peter, for your...
Yeah, and I might just make a closing statement, love. Just for all of you, you know, I hope you're excited by this development. It's been a long time coming. We've had virtually no real treatment innovation that's affected the mental health outcomes now for about 50 or 60 years. The science behind most of our pharmaceuticals is 50 or 60 years old. This is a major potential paradigm shift, which can get a lot more people well and out of the system, leading the lives that we all want people to lead. But the only way we're going to get there is by continuing to build pressure in the system for change. Yeah. So, you know, we need all of you, as we mentioned before, to get involved in whatever way that you can. Go onto our website, learn about what we're doing, learn about the science and the data, and then spread the word. Because the sooner this happens, the better.
Just two more quick comments, just questions, sorry, that have come up, or really good points. Josh, Josh, you seem to have a lot of really good thoughts here. Josh, Gavin, I think you can probably see Josh's comment here.
Yep. Wouldn't
it make sense for a public-facing campaign to drive education and fuel demand? So, Josh, would you like to reach out to Gavin? And I'm not sure what your background is. You don't have your camera on. Hello, Josh. Hi. Where are you based, Josh?
Hang on, I'll unmute you, Jess. Here you go.
Wodonga, Victoria.
Okay. Well, firstly, I think we were starting a chapter there. I don't know what happened to it, but you might want to... Are you a practitioner, or are you a patient, or are you a caring...
Interested patient.
Interested patient. So maybe you might want to connect with Gavin, who's leading a lot of our public-facing campaigns, to work out what would be some really cool strategies.
Sure, sounds good.
Gav, would you mind giving...
Yeah.
Yep, so Gavin at mindmedicineaustralia.org.
That's
and
a good point
Caroline.
It's a good point you make, but it has to be both the patients and the clinical people.
Yeah,
I agree. I'm just thinking from a numbers perspective.
No, you're making good sense.
You're spot on.
Yeah.
Caroline, to your comment, so it was PACFA, not APA. So PACFA actually does recognise, as do all of the peak bodies in Australia, recognise the training, and you can get CPD points through PACFA for this training. So Caroline, if you're a member of PACFA, please do apply. And then this iPhone person, Deborah Greentree, has had her hand up for ages. Deborah, do you have a question?
I've asked her to unmute.
Deborah, if you do have a question, you can unmute yourself. If not, thank you all for your wonderful participation. It's been a good session, and yeah, super grateful to you all. Blessings.
And come back with any questions and go onto the website and please stay in contact.
Yes, please do. Thank you all.